78-year-old lady comes into your emerge. She's got congestive heart failure. She's had a cough. She's sort of tired for a few days. She's tachypnic, satting poorly on 100% oxygen, right? You're a smart doctor, so you try her with some BiPAP, except she's claustrophobic and it goes really poorly. And so you decide to intubate. Everybody in emerge, I find from day one, knows all of the indications for intubation and can rhyme them off. And we spend sessions and sessions and sessions on how to intubate and RSI and how to do a VL and everything else. And then we really give you nothing about the ventilator. And in fact, Rosen's only has 7 pages on vents. And like 2 of them are historical perspective. So you don't need to read those 2. So this is where we're going to try to give you some practical knowledge that makes it easier for you at the bedside when you're doing this. So at the most basic level, a ventilator just blows air in. It doesn't even suck it back out. All exhalation is passive. That's the patient's chest wall recoiling, right? So it just blows it in. And a ventilator buys you time, as the smart doctor, to fix the underlying problem and save the patient. The vent in and of itself fixes almost nobody, with the possible exception of some CHF, right? Otherwise, it's still up to you, or the ICU, or whoever to fix the problem. The vent is buying you time with oxygenation. So, setting a ventilator, the concept most people go with is inflating the lungs is like inflating the balloons. If you want the balloon to get bigger, you got to blow a bit harder, a bit more volume or a bit more pressure. If you want it smaller, you blow a bit less. If the balloon is really thick, you're going to have to blow harder. If the balloon is really stretchy, you don't have to blow as hard. If it's full of water, it's different, right? So all lungs are a little bit different. So the settings any given person needs are going to be a little bit different. We all have slightly different balloons inside of us. Okay. So when you're setting how you're blowing the air in, there are 2 main things to set, which is how the breath starts and how the breath finishes. Okay? Because that's all it does. You're just setting how the air is blown in, and the vent's going to do that over and over. How it starts is sort of binary. There's either a time parameter or it's patient triggered. So a time parameter means you set, say, a rest rate of 12. That's a breath every 5 seconds. So every 5 seconds, the vent timer goes ding, and it blows in a breath every 5 seconds. Boosh, right? The alternative is that the patient is triggering and breathing on their own. The patient starts to take a breath, the vent registers that negative inspiratory force and delivers the breath you've set. Okay? The thing to remember here, and this is sort of back in the 50s, I think vents were actually binary. Now it's important to remember that all vents can do everything, right? Pretty much. They can all do a blended variety of modes. But when you're trying to understand the differences in the modes, this is the main breakdown. Okay, so breath starts either by time or by patient. And then I think the only hard thing about vents is that we use 12 different words to describe the same concept, and people get mixed up in the words, right? Or in what the acronyms are. And we have a lot of acronyms in the ICU because it makes us feel good about ourselves. But really, the concepts are very easy. So if your vent is starting based on a time parameter, that is called a controlled mode of ventilation, or it's called full ventilation. The patient is fully vented. That's what that means. The vent is triggering based on time. If the patient is breathing on their own, this is called a support mode or a spontaneous mode. Okay? Lots of different words that all mean the same thing. How the breath finishes is pretty simple. You either set a pressure limit or you set a volume limit, and the machine stops blowing air when it hits that parameter. That's it. Right? So there are 2 ways to start and 2 ways to finish. And all you're doing is setting how the air gets blown in. All right. When you set a volume, so you're setting a volume limit, you're saying stop blowing when you hit this volume, right? The vent's going to deliver that volume no matter what. It's a dumb machine. It's not thinking on its own. So every time, it's going to try to deliver that volume. What's your pressure going to be? Pressure is going to vary depending on a whole bunch of things. What size of the balloon, size of the patient, what their underlying disease is. So it's going to vary between patients. It's also going to vary within the individual. Say they start out with wicked CHF, you give them 100 of Lasix, 6 hours later they've diuresed. the pressure they're going to need 6 hours later is different from the pressure they're going to need at the beginning. So if you're setting a volume, your pressure is going to vary. And you always want to be looking at your pressures, checking your pressures to make sure they're okay. And we're going to talk about what okay means in a minute. The converse is when you set a pressure, your vent's not clever, it's just going to deliver that pressure every time. Yeah? So what's your volume going to do? It's going to vary. Both, again, between patients and within patients as their disease changes or as your medical management fixes them. Okay, so if you set a pressure, you're looking to make sure the volumes are acceptable. You set one, check the other, right? Set a pressure, check a volume. Set a volume, check a pressure. So, let's put this all together. You either have your breath starting by time or patient, or there are a variety of hybrid modes here. And this is the concept I'm telling you that all vents can do everything. Okay? You can have a combination of patient and clock triggered. So what this is called historically, and this is the Rosen way, is that if it's purely a time parameter, that's controlled mechanical ventilation, CMV. If it is a hybrid, a combination of a clock and patient triggering, that's SIMV, synchronized intermittent mandatory ventilation. And if the patient's doing it, it's a support mode or a spontaneous mode. So the Rosen's chapter breaks down explaining vents to you based on these 3 modes. These are the 3 that you need to know by the time you're writing your exam as a PG5. These are the 3 concepts. The issue is that nobody uses those words at the bedside, or extremely rarely, I would say, at least in my ICU. You could tell me in a minute what you use in your ICU. But this translates to words you may be familiar with. So CMV modes is also known as assist control. At least at Sunnybrook in Toronto is the only hospital that uses assist control, but that's their mode. They love that. Pressure control, volume control are SIMV modes. Pressure support or BiPAP are spontaneous modes. CPAP, spontaneous mode. What modes do you guys use here in your ICU? Do you know? AC. You use AC, okay. That's cool, you're like Sunnybrook. Anything else? VCV, volume control, and PCV. Yeah? Okay, right? So these are the terms that get used at the bedside, and where people have difficulty is mapping that back onto what that means. But it means something very simple. It either means that the machine is triggering an event based on time, or the patient is triggering. Okay. So let's talk just through the modes for a moment, just to make sure we all have these fixed in our minds. Controlled mechanical ventilation. Your breaths are delivered at a preset rate each time a full breath is delivered. So this is your assist control. If you guys are assist control place, every breath looks the same. This is great if you're paralyzed or heavily sedated, because you don't have to worry about the patient breathing spontaneously. The machine's doing it on its own. Now you can trigger a spontaneous breath because, remember, it's a little bit blended. So in the 50s, CMV was just CMV. You couldn't breathe above. In 2016, CMV, you can still take a breath above, but every breath you take, the vent will deliver a full breath to you. So it ends up looking like this, where all your waves look identical. Each breath has the same area. Each breath is the same. Are you with me? Questions about CMV? Okay, you're still with me. SIMV. This is one of our hybrid modes. So you're going to get a full breath delivered at a preset time on the clock by the vent. And then in between, if the patient triggers a breath, they can have their own breaths where the volume they get is supported a bit by the vent, typically, but the amount of support that you get varies. So in this, breaths are variable. You get these machine-led breaths, and then your own spontaneous breathing in between. This was developed so that if you were on CMV but taking a lot of breaths above, and each of those breaths was a full breath, you could get what's called breath stacking or dynamic hyperinflation, which we're going to come back to in a few slides. Okay? So this was meant to help you fully exhale down here to avoid breath stacking. Pressure support is typically the easiest one for people to understand. It's initiated by the patient, so patient starts to take a breath, and the vent will help them out, help deliver some pressure to that breath. So supports patient effort. Your tidal volume will vary, usually on a breath-to-breath basis. Why is this? Who's got a theory? Patient effort. right? So it's going to vary based on patient effort. The more the patient pulls, the bigger breath they're going to get. Patient only gets a small breath, they're going to get less. So this is a combo of both the machine effort and yours. And your effort, or your patient's effort, I should say, will vary between breaths, which is why your tidal volumes are going to vary. Typically, we set a backup rate here, which is a clock-based rate, in case they go apneic. So even when you're delivering pressure support, you have a backup of CMV or SIMV set on the vents, which is, again, what I'm talking about all the vents sort of doing a little bit of everything, right? For safety, they all have a backup rate set. This is thought to be better for awake patients, used for weaning, more comfortable. That's the overview of the 3 rows and modes. Are you still with me? Not commonly tested, but worth knowing. There are things in life worth knowing even though they're not on the quiz at the end. Okay, so this was our summary, right? We understand the breath is starting by time or the patient. How this breaks down to our modes. Our modes are either limited by a pressure or a volume. You're always setting a pressure or a volume, which is how the breath stops. The thing to remember in case you need this even easier is that in a paralyzed patient or an apneic patient, there is no difference between CMV and SIMV. If you're not breathing spontaneously at all, there is no difference here. You're just getting a time-based preset breath, right? Yes, okay? So those two collapse down into really one category. So the easiest way I find to think about this in the emergency department, if you have somebody who's apneic, you have somebody who you've just RSI'd, you need a controlled mode where the breath starts based on the time. You need to set them on one of these. Whichever one your institution happens to like, or your personal fave, or the one you can remember the settings to. If they're awake, they need a spontaneous mode where they are triggering something like pressure support, or a BiPAP or a CPAP if you're using non-invasive. Okay, so a controlled mode or support mode based on whether or not the patient's taking spontaneous breaths on their own. Yeah? Yeah, questions? Yes?
So in terms of trying to decide whether you're going to second control volume versus pressure,
Yep.
Rose talks about data and someone using volume and you're going to get
Yep.
from a practical perspective, like you're choosing a volume setting for the patient who is hypervocal, has lots of air volume to begin with.
Yes?
What kind of pressure would you
Good, great question. Okay, I don't know if everybody heard that. The question is, if you're using, if you have a difficult to vent patient and you're choosing a volume, but your pressures are sky high, what do you do about that? Okay, so we're going to come back to this precise thing. If in about 15 minutes you don't think I've answered your question, stick your hand up and we're going to do it again, okay? Okay, setting a vent. So what else do you need to set? We've talked about mode and limit. What else on your vent? Okay, wait, let's have a pause. Do you guys set the vents here? Does the RT do it for you? Does the magic RT do it all in the background like a miracle? Oh, it's beautiful. Do you ever have to adjust it? Like when you get a gas, do they come talk to you? Or is it just like magic, they look at the gas and they make it pretty? I love the magic. Okay, so this is part, though, the sad part is this is why we don't learn how to use vents. We have the RT magic in Toronto too, but if you ever go and work somewhere smaller where, God forbid, you're the one making the vent settings, it's worthwhile having a bit of a window on this. If you're going to do transports and you're the guy or the woman setting the vent, that's a big deal. If you're going to do patch calls and get calls from medics who are transferring people on vents, you need to know some of this. Depends where your career is taking you. At many of the small centers, you write the settings and then the RT will dial it in. Period. They don't do it for you. You got to write it down first. Okay, so we've talked about setting a mode and a limit. Other things we need to set: PEEP, FiO2, I to E ratio, respiratory rate, etc. Right? And Rosens takes us through all of these. So, a brief slide on them. PEEP, positive end expiratory pressure. Everybody should have a little bit of PEEP. This helps keep your end alveoli open. This is a good thing for you in terms of oxygenating. Keeps end alveoli open, gives you better VQ matching, gives you more lung parenchyma to oxygenate through, right? It helps counteract the resistance of breathing through an endotracheal tube, which is considerable. Has everybody tried breathing through an endotracheal tube? No? Really? Okay, so the next time you're at an intubation, and you know how the RTs usually like prep one, but then have a second one there, or sometimes open and ready to go? Like if you want two sizes of tubes. If you ever don't use the second tube, but it's already open, you have to throw it out. So just try it for a minute. Just hold on to it and try breathing through it. As an exercise, it's interesting. You'll realize how hard it is, and then you'll never forget about PEEP. Okay? It increases your functional residual capacity, improves oxygenation. What are the downsides to PEEP? How does this hurt people? Barotrauma. So it's too high, too much PEEP, lungs overexpanded, you're going to pop your balloon. Causes obstructive shock. Perfect, right? So as the lungs get bigger and bigger and bigger, harder for you to have effective preload, harder to have effective venous return, decreased preload, decreased cardiac output, right? So you can drop your pressure. For the same reason, it can keep your ICP up, worsens jugular venous flow back into the heart as well, worsens pneumothorax, or pops you a new pneumothorax if you didn't have one before. Okay? So pressure curves, I'm only going to give you one pressure curve because I know people hate them, but it just gives you the concept of if this is your airway pressure here, and this is time, so you're breathing. This is inhale, exhale, inhale, exhale. If your normal pressure down here is 0, PEEP is maybe giving you 5 centimeters of water above that. That would be a standard PEEP setting. Then you get a driving pressure on top of that, or an inspiratory pressure that gets you to the top of your breath, end expiration, then you exhale. Okay? So your peak inspiratory pressure is going to be the same as your PEEP plus your driving pressure. People also call this your PEEP plus your inspiratory pressure, or your PEEP plus your delta P. And we again are back into the confusogram where people get lost by the different terms, which all mean the same thing. But there it is. So your peak is going to be your PIP plus your, see, I've just confused myself. Your peak inspiratory pressure is going to be your PEEP plus your driving pressure. Okay, questions? Okay, I to E ratio, this is a pretty easy one for people. This is the amount of time you spend in an inhalation versus an exhalation. Normally, inhalation is faster, it's active. Exhalation is slower, it's just passive recoil. So a normal ratio is going to be about 1 to 2. Anything that has a long E time, any obstructive disease where they have a long expiratory phase, you need to give them more time to exhale. So a ratio of 1 to 3, 1 to 4, 1 to 5. So here's what the magic RTs are doing behind your back. They guess a starting point. This may be, so Rosen's in fact gives you a starting point, so you don't have to guess your own. You can memorize the Rosen one, which you will probably do before your exam, and maybe just for life in general. You start there. You try it for a minute. If you've set a volume, you check to see if your pressure is okay. If your pressure is too high, you got to turn your volume down. If your pressure is too low, you got to turn your volume up. And the converse is true. If you set a pressure, you check to see that your volume is okay. That's all they're doing at the bedside. They are adjusting the pressure or volume up or down to make sure that the converse is adequate. When it's adequate, then they're looking at the monitor to say, hey, does my patient still have a blood pressure and a decent sat and a decent heart rate? Yes, they do. Marvelous. I'm done. This is hard for people because there is no cookbook, because it varies between individuals. I can't tell you the one magic set of settings that are going to work for everybody. It doesn't exist. But that's what the RTs are doing at the bedside, standing there at the vent, twiddling the dials, when you have finished intubating and you're walking away to call ICU. They're just trying it. They just pick a number and they try it, and then they adjust right there at the bedside on a breath-to-breath basis even. It's not something where you need to wait 5 minutes and see how they do. Right there, they're turning it up and down. Okay? When they're happy, when they tell you they're happy, when you're happy, ideally, sedating the patient, getting a chest x-ray, checking a gas in 20 minutes. So the volumes or pressures you're getting are a reasonable indication that you are ventilating safely. The gas helps you determine that you are ventilating adequately, that you are in fact normalizing their pH or giving them enough oxygen. So anybody should get a gas, 20 minutes, half an hour, something like that, after your intubation. Okay, so here's what Rosen says. Rosen says, start at an FiO2 of 1 and titrate down. We know hyperoxia is not that good for you, so we're shooting for, a SAT somewhere in the 90s usually for most people, but it doesn't need to be 100. Your rate, 12 to 14 breaths a minute, is kind of a reasonable starting point. I to E ratio for normal people, 1 to 2. PEEP's a 5. The exam answer, the PEEP is always 5, is perfectly fine. You can always say that and pass your exam. Mode. We've talked about mode. So a support mode if they're awake, but probably you've RSI'd them. Most of the time, have you RSI'd them? So you're probably choosing a control mode. And here's the limit, the pressure volume issue. So say you're setting a tidal volume, 6 to 8 cc's per kilo is considered a standard, right? So say I choose 6 cc's per kilo to start. The vent's going to blow in that breath every time. I'm going to check to make sure my peak pressures are okay. Less than 30 is a nice number. You can take it higher if you want. Alternatively, if I choose to set a pressure, usually start 10, 12, 14, something in that ballpark. See what kind of volumes you're getting. You want to achieve a reasonable tidal volume, 6 to 8 cc's per kilo. This does require the single math step of figuring out what you think they weigh and multiplying it by 6. So there is some math involved. Question?
Is it better to use the patient's ideal body weight?
Yep. It is better to use their ideal body weight. Yep. Frankly, though, let's be serious. At the bedside, I don't know anybody's ideal body weight, so I kind of go, 70 kilos. Unless they're huge, and then I choose 100 because it makes the math easy. Yeah. Right, you want to be in the ballpark here, people. This isn't like deciding that they are in fact 78 kilos and setting it precisely to that doesn't get you a lot further ahead as long as your numbers are okay. This is perfectly okay to ballpark and try. That's what happens every single day in all of our EDs and ICUs. So look at them. Be like, they're about this. Okay, I'm going to try that number. And then you adjust based on your guess. This setting a vent is pragmatism at its most basic. Okay? Questions about the Rosen settings? We're going to come back to them. Work on putting them into your brain. Okay. Okay, so here's our lady. She was 78. She had congestive heart failure, weak cough. She was tachypnic. Remember this? She failed her BiPAP, so we intubated her. We did an RSI. Okay. So what do you want your initial vent settings to be? Tell me what you're going to set. Okay, good. A controlled setting, yes, lovely.
I'm going to go with volume because
Lovely, we're going to go with volume control because we can remember 6 to 8 cc's per kilo, yes?
how big she is. But you say
She's going to be 70 kilos.
so I'm going to set her back to 500 and 7 times 7 kilos is 490.
Lovely, so a tidal volume of 500 cc's each breath.
I'll put her at a rate closest to whatever she's just breathing at.
Okay, so her rate was like 35. Do you want to go that big?
I don't want to breathe such a big shit, probably makes her a little slow enough.
Yeah, so she was breathing fast because she was mostly dead and she was trying to oxygenate. Now that you're helping her with the tube, you could probably go a little lower, but it's a good thought. So maybe you start at the Rosens 12 to 14, or maybe you say, hey, she was pretty tachypnic, I'm going to try 15, 16, 18. Okay, perfectly reasonable. FiO2 100, and then you could titrate that down just while you're standing there at the bedside based on their SAT, right? You don't have to wait for a gas to titrate that down. You can roll it right down in those first few minutes. Good. You want some PEEP? What's your PEEP going to be? 5. What's your I to E going to be? 1 to 2, right? Okay. Did we do it? We just set our whole vent, right? You're choosing a controlled mode because you paralyzed. I chose a pressure. You could choose a volume. Either really is okay as long as you're looking at the outcome. FiO2, I dialed it down. I put a respirator of 12, PEEP of 5, IDE 1 to 2. Okay? Any reasonable number here is an okay starting point. And then you adjust it based on how your patient is doing. So there really, I mean, I don't want to say there isn't a wrong answer, because it's probably wrong if you've just paralyzed to put them on pressure support and let them be apneic. Like they're, you know, and PEEPs of 55 is probably wrong. But anywhere in the ballpark is perfectly acceptable. Okay, so you're going to do a gas within 20 minutes. You're going to adjust the vent based on these results. Writing orders for sedation and analgesia are really nice. This is something, at least in Toronto, we do really poorly. I don't know how you guys do here. So we tend to RSI them. And then we're like, whew, victory, I'm done. So I could take my gloves off, and the RT is going to manage the vent. And I can go get my coffee. I can go call ICU. I could go pick up the chart, whatever. But you know that vibe where you're sort of done? My ask to you is to at least write a sedation order or an analgesia order. Having a tube in is uncomfortable, and it makes it hard to ventilate them. Because I want you to think about this for a second. You've put them on a controlled mode and you've paralyzed them. Your paralysis is going to wear off in a little while, depending on what you've used, maybe a very short while. And then what's going to happen? They're going to start to breathe on top of your settings. Your vent's going to start alarming. It's going to start annoying your nurses. You're going to have to call the RT back, right? Just sedate them up front, and you spare yourself that having to go back. And it's a humane and lovely thing to do. It works all around. Okay, so you get a gas. Here it is. What kind of problem is this? Who can interpret the gas for me? It's a respiratory acidosis, right? So you are acidemic right here. Your PCO2, which should be 40, is 78, so that's high, extra acid, respiratory acidosis. Your PO2 is reasonable. Your bicarb's 25, just a tick up. How do you adjust the vent to fix this? What do you do? What, in fact, is your magic RT going and doing behind your back to make your gas better? You need to increase her minute volume. You do. What's your minute volume? Your rate times your tidal volume. These people had coffee. So you can either, he's like, yes, I did. So you can either, as you should, you can either increase your respiratory rate, or you can increase your tidal volume. You can increase the size of your breath, which is either going to be turning your volume up a bit. So you started at 6 cc's per kilo, maybe you're going to 7. Or if you started with the pressure mode, you're turning your pressure up to get a slightly different volume, right? Marvelous. So when you're adjusting the ventilator, we really think of it in two streams of problems. There are oxygenation problems, and then there are ventilation problems, because these are different moves on the ventilator. How, if you have an oxygenation problem, how are we fixing that on the vent? FiO2 and PEEP. Lovely, right? So your PEEP and your FiO2 are the two things you can dial up to help you oxygenate more effectively. Then you also have smart doctor moves, right, which are nice. Smart doctor moves are doing things to improve their oxygen delivery. These are medical things, not vent things, like maybe they need a transfusion, like maybe you need to give them antibiotics for their pneumonia, like maybe you need to diurese them for their CHF. Ventilation problems, as we discussed, is a combo of either increasing respiratory rate or driving pressure or both, and also still includes smart doctor moves of decreasing how much CO2 you're producing, fixing their COPD medically, yeah? Sedating them, treating their fever, feeding them less. All sorts of things will decrease how much metabolic CO2 you deliver, and are marvelous doctor things that are totally in our wheelhouse. Okay, so case one. We've learned the Rosen's initial settings. We've learned to write sedation orders before you walk away. It's pretty easy. Just pick your benzo or your propofol or whatever other drug you love and let the nurses run an infusion. And adjusting the vent based on the gas. Questions so far? Before we take it up a notch. We're good? Question? No. Yes. Sure. So the question was, do we do inverse ratio ventilation for people who we can't oxygenate? Yes. We see severe asthmatics, who are the common one where we just can't oxygenate them, or occasionally severe ARDS. I've got to tell you, we do it mostly in the ICU, not in the emerge. So an inverse ratio means rather than having a short I time and a longer E time, I switch it. So I have a long I time and a short E time. I time, inspiratory time, is my oxygenation time. So for somebody with refractory hypoxia, extending that is helpful. The problem with the short E time is breath stacking and dynamic hyperinflation. So you need to do it in a setting where you can watch them really closely. It would be very rare for us at our place to do it in our emerge. Do you guys do it in your emerge? No, not so much. And usually, I've got to say, if I'm really inverse ratioing somebody and I'm worried about it, I've got bilateral chest tubes in before I even start. So I don't care if they blow the pneumo. I, in fact, anticipate that they will. And you just put the tubes in. Carry on. Yeah? Question?
For pressure, when you set for a pressure level,
Yes.
is it the delta, like the inspiratory pressure, is it the delta, or do you set it as the total additional to the PEEP? Like,
You're setting the delta.
you're setting the delta.
Yes, which is where the terminology becomes confusing. So if I am setting a pressure control of 10 on 5 of PEEP, my peak pressure is 15, and I'm setting 10 on 5. I'm not setting 15 on 5. Okay? Depends a little on your vent. My vents, that's what I'm doing. Some of the transport vents are certainly different. That's my vents. It's a great question. And I don't know, so particularly if you have magic RTs, my RTs are so smart and so good at this, but they're lonely people. We don't talk to them that much. They just get called back to deal with the gas and then they go away. If you actually go to the bedside for 2 minutes and you just say, what are you doing? How's that working? They are so willing. I find mine are engaged to teach. They're lovely people. They could tell you all these pearls in about 90 seconds that make it so much easier to understand ventilators. The next time you intubate somebody, you may want to just spend 5 minutes with them to just be like, hey, how are you doing this? What settings did you choose? They probably didn't choose the Rosen settings. That's okay. But you could talk to them about why. And you learn a lot just by standing there, seeing how they're twiddling the dials. Okay, next case. 68-year-old guy, he's been short of breath for a while. He is desaturating. He's got underlying COPD. It would probably be perfectly reasonable to try BiPAP on this gentleman, except this is a ventilation talk, so that's not going to work. We're just going to intubate. And I can't let it work today. You guys are doing marvelously with your intubation. It goes perfectly. And now we're going to ventilate him. So these are our initial settings that Rosen tells us to use, right? We're learning these. Is this what we want to use? Because Rosen gives you a starting point that you, as a smart person, are now allowed to modify. And in fact, they give you suggestions about how you may want to modify this. Is there anything you would want to choose knowing that the problem is COPD?
I would change your IDE ratio.
I would change my IDE ratio. Yes? What would you change it to?
1 to 3.
Sure. 1 to 3. Lovely. Anything else? It's okay to say no and just start here and try and see what you get at the bedside. Yeah? So we decided to go with a slightly bigger tidal volume, still in the normal range, but on the higher side because this guy had crazy hyperinflated lungs on his x-ray. Turn the PEEP up a little bit. He was tachypnic. We went at a higher rate and IDE 1 to 3. Okay? But you choose something reasonable and then you see how he's doing at the bedside. Okay, so at first it looks really good at the bedside, and then my settings fail, which sometimes they do. So what now? You had just gone and picked up your coffee. The timing is really bad. And the nurses call you back. They're like, we need a doctor in bed 7. Okay, why are you taking him off the ventilator immediately? I like it. Why are you doing it? Sure, right? Remove the complicated piece of machinery from your cognitive workload. Take it away and turn it right off so the alarm doesn't go off and annoy the hell out of you over the next little while, right? Just bag. Good?
And then
Make sure the tube is where it still belongs. And yes, and that it's not kinked. You can put a suction catheter down it, make sure it's still intact, not blocked by secretions. And then probably chest tubes, right? Nice. So little ACLS is lovely too. Here's what I do. I'll tell you what I do, which is pretty close to what you just said. Absolutely, you take them off the vent. Any arresting patient on a vent, take them off. Just take it out of your workload. You can deliver high volumes and pressures by bagging, higher in fact than what you can use on a vent. And you can tell, is air going in easily? Is it blocked? Am I able to expand the lungs? I take them off, and in fact, I wait for 20 seconds for them to exhale. So I tell my RT, take them off and don't bag. Don't bag. Don't bag. And they still want to bag. They want desperately to bag, so you have to say don't bag about 5 times. And by the time you've said it about 5 times, probably 20 seconds has gone by, and then you're like, okay, now you're good. Go slow. Okay? Pressing on the chest. The CPR helps here if your problem is dynamic hyperinflation. So we're going to talk about what that is and why this helps. Because the list of having COPD and dying within a few minutes of your endotracheal tube is actually relatively short, common things being common. Common things are the pneumothorax or PEA based on low cardiac output, and that's either, they may have been hypovolemic to start with, or it may have been your induction meds that vasodilated them and dropped their pressure. That's possible. But it could also be this concept of dynamic hyperinflation. Who knows what that is? Before I tell you how I think of it. Yes? Yes? Yes, right? So dynamic hyperinflation is this concept of the breaths are coming too fast or too big. You're not having adequate time to exhale. So each breath expands you and partial exhale. Expand, partial exhale. Expand until your lungs are blown up like a giant balloon, huge pressures, and no venous return. No venous return at all, right? High pressures, hypotension, and then PEA. This is worse in diseases that have a long E time, that need that extra time to exhale. If you're a visual person, it looks like this. So normal breathing should be inhale and then full exhale back to the baseline, right? That's normal, that's lovely. Breath stacking looks like this. Partial exhale, inhale, partial exhale. Each inhale on the vent is probably still giving you the same breath, right? Depending on how you've set it. If it's on a volume, the vent's still pushing in the same volume each time until you're up here and your lungs are way overinflated with a huge trapped tidal volume and you arrest. So taking them off the vent, off the circuit, and pressing on the chest helps squeeze all that air back out. If that was your problem, they're going to get their pulse back within the first minute. If you take them off the vent and you let your RT bag like mad, they don't have time to exhale and you won't get them back. Have them pause. Just 20 seconds with some CPR will empty the lungs, pause and regroup. Okay? Okay, so COPD arrest, the arrest shortly after you've intubated is going to be usually, common things being common, one of these 3 things. Dynamic hyperinflation, hypovolemia, or pneumothorax. So our algorithm is we take them off for 20 seconds, we bolus them, or if we think it's an induction agent issue, then push dose pressors here would be useful, get you back some blood pressure in the meantime. And then we needle both sides of the chest. We've stopped doing the, I'm going to listen. I know you're doing CPR and somebody's bagging and somebody else is counting and somebody's asking for epi. Like you cannot hear, I think, if you can hear and you can tell which side the pneumo is on, God love you, just needle that one side. But I can't tell. I just needle them both. I will not call this arrest without needling both sides of the chest. You should probably never call this arrest without needling both sides of the chest. Questions? Yes.
Kind of like figure out that this is dynamic hyperinflation. Let's say like I'm watching it afterwards. Like
Yeah.
your giveaway, I guess, would be like you see like pressures like your pressures like increasing with time giveaway.
Yeah, so there are giveaways on the vent. So your peak pressures are going to increase. The vent's going to start alarming, typically high pressure. It might alarm that it's not able to achieve the tidal volume you set. And so it typically will alarm as this is going on. Okay? Yeah, it's a good thought. So if you go and you read your alarm, that can help you avert it before this happens. We're going to talk about vent alarms in just a minute. Yes, question?
Question about needling the chest. What is
Yeah.
your timing for doing that? In a situation where the patient has coded their PA arrest,
hear you. I don't find needling it typically makes my life worse, but sometimes, on rare occasions, it does. Here's the thing. It depends what your pretest probability is for hypotension. So you are the person who knows what their baseline blood pressure was beforehand, and you know what kind of induction you gave them. So if they had a questionable blood pressure and a huge induction, then I would wait and I would give them volume and I would give them a pressor. I'd give them some phenylephrine or ephedrine or whatever you keep in your pocket when you're doing it. If they had an excellent blood pressure, and during my RSI, they keep their excellent blood pressure, and I know 2 minutes after I intubated, as I was walking away, they still had their excellent blood pressure, it's probably not my sedation. It might still be, but in those cases, I'm not going to wait very long. I would needle them in the first couple minutes. Okay? So it depends. I mean, this is where you need to be a smart doctor. You adjust this list based on the clinical probabilities that you're seeing in front of you. It's just important to know what's on the list. Okay. Young lady, diabetic, presents short of breath and vomiting. Her GCS is about 11. Based on her labs, you think she probably has some DKA. She does have this short of breath and sort of oxygenating not that well. So you do the chest x-ray, which gives you some further information and maybe makes you think things aren't going all that well. But you start excellent medical management. You get a gas. So you're delivering excellent sepsis and DKA care. Your gas shows, what does your gas show? Apart from badness. Metabolic acidosis, yes. And what's she doing with her respiratory rate? It's really high. She's breathing like mad to blow off the CO2 to try to compensate for the low bicarb. And she is able to breathe it off to bring her pH up to 6.9, but not a lot higher than that, right? Bad. If she was a 70-year-old person, she would have already arrested, but 20-year-olds can do this for a little while. Okay, so you're doing your stuff. You're doing volume, you're doing antibiotics, you're doing some insulin, you're doing whatever you feel like doing. And then she throws up all over the place. She aspirates, things start to go downhill. These are always my real cases. I like to tell you about my disasters. Now the stat's worse, you go ahead and intubate, because everybody gets intubated in this talk. Why do people always say, don't intubate DKA? Because they breathe way better than you can achieve with a vent. It is really, really hard to match somebody like this, particularly a young person. They breathe fast and they breathe huge. It is actually technically hugely difficult to achieve that on the vent. So it's not that the intubation in and of itself is the problem, it's the ventilating them afterwards. And it's the fact that if you RSI them and they have a minute of apnea, which is a minute of not blowing off that CO2, letting the CO2 rise. As the CO2 rises, the pH goes down. pH goes down too much more, you're into PEA from acidosis. Okay? So you need to be fast. And then you need to bag the hell out of them. So your initial settings, are you going to use your Rosen's initial settings? No, right? We're going to adjust them. You're going to uptick them to try to match her rate. The severe acidosis person is the person you really want to match. Okay? And we've talked about how you're doing this. You're matching based both on tidal volume and respiratory rate. And this is the person where you're going really big. Yeah? So this is the one patient where I count their respiratory rate before I intubate them. I never count anybody's respiratory rate. In general, I got to say I don't really care. I do the sort of end of the bed vibe of how is that going. This is the one person where I count. And you got to do it, let's remember, before you intubate, right? Because after they're paralyzed, they're not breathing anymore. So while the nurse is getting the drugs and the RT is coming down and I'm putting my gloves on, I put them on at the end of the bedside and I personally count their respiratory rate because I want to know what to tell the RT after. Okay? This is the one person where I actually count. Tidal volume's huge. So we chose volume controls of 12. Rosen says normally 6 to 8, so we doubled that. Tidal respiratory rate of 26. Again, sort of double the Rosen's initial setting. And we tried it. It held me for a little while, but probably not long enough. PEA rest from acidosis. So, again, take them off the vent and bag them. You can deliver huge tidal volumes and high pressures very fast on a bag, much more effectively than on a vent. And the metabolic acidosis arrest is the person that you want to bag like crazy to shift that PCO2, to blow off all that PCO2, let their pH come back up. Okay? So you're doing your ACLS. You again always have two choices, optimizing medical care and optimizing the vent, or ideally both. So while she's still getting her excellent sepsis, ACLS, DKA care, we now took her tidal volumes up to 14 cc's per kilo and bumped her rate up a lot more. Okay? With that, she had return of spontaneous circulation after about 5 minutes, went to the ICU, and then home. But these are the people you want to be really afraid of. The metabolic acidosis for whatever cause. This could be DKA, could be bad sepsis, could be aspirin. It's not the intubation that's hard, it's the ventilation. Questions about that? I've got one last super quick case.
More of a tangent question, but very few cases are using Bicarb boluses at all? Or?
Sure. So there's no evidence for Bicarb. So you'll find different people have different Bicarb strategies. pH less than 7 in a person like this, I'll give them some Bicarb. Different people have different limits. Some people say 7.1, 7.15. Yep. Okay. Say, this is what happened to me. I'll tell you my case. So I come on to work at midnight. I'm doing the night shift. And the sign over is, oh, there's an intubated guy in bed 8. He's waiting for his ICU bed. But he's like, he's not mine. I didn't intubate him. I don't have ownership. I'm just working. And then the vent alarm goes off. And 8 is a room I can't see from where we hang out in major. Like, it's not in my direct line of sight. So what do you guys do when you're in your emerge and the vent alarm goes off? Sorry? RT, yeah, you duck, right? Do you suddenly get really busy somewhere else? That's what everybody at my place does. So somebody says, call the RT, and then everybody gets very busy somewhere else, so they don't have to be the person to go in and do anything with the vent, which I've done. So I'm going to tell you my story so that you can share my shame. But really, we could probably take it up a notch and do a little better with the vent alarms. So I am going to give you the world's easiest approach to the ventilator alarm. So you walk over. So the first thing is you walk towards the bed rather than choosing that time to pick up a chart and walk somewhere else and make yourself busy somewhere else. Then you read what it says, because I believe that you are all excellent readers, and I feel that you have the capacity to look on a ventilator and there will be something red and flashing, and you will need to read those letters. It will say something like low VT, low tidal volume. Or maybe it says something else. It doesn't matter. It's going to say something. It might say high pressure. It might say low volume. But you can read. And then at minimum, you are ahead of the curve on your RT page where you can say, there is a high pressure alarm. Can you come help me? Or there is a low volume alarm. Can you come help me? So already, seriously, I'm actually not even kidding. If you walk over and read the damn machine, you are way ahead of average. Just right there. But now you happen to be a pretty smart person. And there is lots of easy stuff you could fix. Just even without ever having heard this talk. So here are some things you could fix. Maybe the tube is kinked or caught in the bed rail and you could just take it out. Maybe their tube got disconnected and you could just reconnect it. Maybe they're awake, the overdose who's like, right. Maybe you could just be like, oh, we need to extubate. Maybe they need a suction, maybe they need Lasix, maybe they're super wheezy and you can order some Ventolin. There are lots of smart doctor moves here that you can make. If only you walk over to the bedside first. Because here's what occasionally happens. This is my shame story. So this case, I was a PG2. There I am. It's not my patient. Not really a good excuse. I didn't go over. We just paged the RT, right? So the RT goes into the room. Does their thing, the alarm stops going off, and they come to find me, and they're like, Sarah, did you go look at the patient? I was like, nope, I just called you. And it was a person, had been overdose, intubated for their overdose. They had gone and self-extubated because they had woken up. Nobody noticed. They're sitting there happy as a clam in the bed. They've got no problems. The vent is going crazy and alarming because it's not getting any pressures. She was like, well, You really just needed to unplug the ventilator. And you called me out of a C-section where I was supposed to be there helping the baby. And I was like, oh God, just shoot me now. Yeah. So you could be a smart doctor. You could walk over and see that your patient is just fine without a tube and just unplug the ventilator. There are, in fact, lots of easy things that you could do at the bedside. So I strongly encourage you to just walk over and just have a quick look and read what the ventilator says. If you do just even that, you are way ahead of the curve. All right, so here's what we talked about. Ventilators, the basics of how we set, what modes and limits are, understanding the different modes. Knowing the Rosen initial settings is probably, something you need to achieve sometime in the next 5 years. Knowing how to adjust them is smart, both for specific patients, how to modify them, and then also when you get a gas back, knowing what moves you can make on the ventilator. The COPD arrest is a big one. It's a common one. The severe metabolic acidosis patient is a risky patient. You want to be thinking hard. You want to call for help, have somebody come help you. And just reading the alarm on your ventilator is a big move. Okay, thanks guys. Questions about that? Yes?
Maybe a dumb question, but like...
Oh, there are no dumb questions.
Yeah, well...
He's like, oh, maybe there are. No.
When you're selecting like a tube to patient, I know like,
Yeah.
I have like different choices, but then
Yeah.
like, is there like a huge benefit to choosing like a much larger tube in terms of like the settings that you can see on people? Like, if I give somebody like a 7 versus like somebody has an 8,
Yeah.
then all of a sudden I notice like a profound difference in settings that I can give somebody right now.
Right. So most people, I think you're not going to see a profound difference in tube size. People who are, it's only going to be in the people at the very extremes or very sickest where it matters. Say you have, for example, the super, super sick asthmatic, where you're having trouble. Putting a bigger tube in them makes a difference. Because their resistive workload is so high at baseline, putting a wider diameter tube will help you a little there. It's going to be of incremental benefit, but for the average little old lady CHF, it's not going to make a huge difference. I try to never put anything smaller than a 7. It just makes it easier to bronch if you have at least a 7 when they're upstairs. And if you can put bigger, go bigger. But you don't have to struggle for an 8.5 in the average person.